Hi everyone, welcome to week 5 of Issues in Northern Rural and Remote Health in Canada. This week's issue is health services, particularly the challenges in delivering them to rural and northern populations. I have selected 3 of the required readings to discuss with you guys today. In 2009, we were affected by a worldwide pandemic. Impacts were seen right across the globe. This public health emergency, commonly known as swine flu, left its mark on us and our healthcare system. While all of us were affected, it was Aboriginal communities in Canada who were among those the most affected by this flu. While there are many possible reasons for this, our first paper looks at the impact of one particular factor, geographical location of residents, and the disease outcomes among Canadian First Nations during the 2009 H1N1 influenza pandemic. What are the possible reasons for the disproportionately high rates of severe outcomes in First Nations communities? There are many factors. Some of these include their predisposition for chronic health conditions, transportation barriers, environmental factors such as overcrowding and unsanitary water, poor nutrition, social isolation, and financial barriers. The specific effect of geographical location of residence, which may determine one's access to healthcare, has not been investigated in terms of the H1N1 influenza pandemic. Therefore, this study evaluated the effect of geographical location of residence on hospitalization among First Nations people in Manitoba during the flu pandemic. They used clinical and epidemiological data that was collected during the pandemic. Specifically, they obtained data on confirmed cases of the influenza and place of residence. Rurality was defined using measures from Statistics Canada and the Public Health Agency of Canada. There were 3 categories: urban centre, moderately rural, and remote/isolated. They also looked at place of residence as either living on a reserve or living off a reserve. These data then underwent statistical analysis. They found that on-reserve residents experienced longer delays between infection and hospitalization compared to off-reserve residents. They also found that the average time to hospitalization for those in the remote or isolated category was longer than those in the moderately rural category, which was in turn longer than those in urban centers. These delayed hospitalization times can become a problem because it results in an increased risk of poor health outcomes and ultimately ICU admission. In terms of on-reserve versus off-reserve living, they found that the odds of hospitalization were higher for on-reserve First Nations populations, which contrasts the result that the more rural categorizations had lower odds of hospitalization. Why do these results seem inconsistent? They suggest many reasons, but the bottom line is that something else is at play here. Geographic location of residence is not the sole factor influencing these poor health outcomes. In conclusion, the results of this study do suggest that geographic location played a role in the health burden experienced by First Nations communities during the H1N1 pandemic. But there are also other determinants contributing to this outcome, possibly limited healthcare access or pre-existing comorbid chronic diseases. Our next article, titled Understanding Health Pregnancies, the Perspective of Inuit Midwives in Northwestern Quebec, is an explorative study that uses focus groups to gain perspective. In northwestern Quebec, it is current practice that most pregnancies, about 90%, are taken care of by Inuit midwives. While their midwifery education program is comparable to those in southern Canada, mothers and infants in northwestern Quebec still have higher rates of preventable nutritional deficiencies compared with national averages. For example, infants born in northern Canada have a 4 to 5 times higher incidence of severe vitamin D deficiency than infants born in southern Canada. What are the reasons for these inconsistent deficiencies? This study aimed to understand the perspectives of the Inuit midwives who see it firsthand in an effort to better understand the discrepancies between northern and southern Canada health outcomes. They created a focus group consisting of Inuit midwives and students. Via teleconference, they discussed the local understanding of a healthy pregnancy and a healthy newborn, and the role of midwives in the community. First, we will focus on what they considered a healthy pregnancy. 3 key determinants were food selection, unhealthy lifestyle choices, and the need to support traditional community values. They discussed how parents buy less sufficient food options because they are cheaper. The lack of acceptance of advice from their midwives also arose as a problem. The midwives said that they suggest things such as supplementation, but some mothers don't listen. One midwife said they think of it as medicine. Some people do not like taking medicine. A decline in the amount of community support was also considered, as social traditions are being lost from one generation to the next. Next, we will talk about what they considered a healthy infant. Again, 3 major themes arose: the importance of breastfeeding, infant nutrition through local foods and supplements, and the need for more nutritional education in communities and midwife training. Problems in these areas were also attributed to mothers not taking the advice of the midwives. Finally, they discussed the role of midwifery in their communities. The midwives believed it was their job to inform the mothers about healthy food choices, something that their education allowed them to do. They also brought up the importance of strong community networks and the transfer of traditional knowledge from one generation to another. Recommendations made by the midwives included using multimedia to promote their messages. For example, in an effort to reduce the association of supplements with medicine, they suggested the use of radio advertisements and flyers targeted at mothers. In an attempt to increase the amounts of traditional foods being consumed, they suggested developing a calendar-type tool to coordinate seasonal access to nutritional traditional foods. They also addressed the issue of widespread substance abuse in their communities and suggested further education to those affected. In summary, the midwives were eager to change the unhealthy behaviors of their communities through community involvement and increased health promotion and education in order to reduce the incidence of nutritional deficiencies in their mothers and babies. Our third and final article is a little different. It focuses instead on a possible innovation in rural health service delivery and was actually completed in Nain, Labrador. We know by now that the presence of physicians and adequate health services in rural areas is limited. Often they rely on air transport for getting physicians in, which is problematic as it is dependent on financial resources and weather conditions. Telemedicine has offered a solution to this problem, however, it has not yet been seamlessly implemented. The study explored the practicality of a remote presence robot that can determine real-time physician expertise to remote areas. They conducted this trial in Nain, where there is a clinic with just 6 regional nurses. Emergencies and diagnostic care require air transport to Happy Valley Goose Bay. The doctors also come via air or communicate by telephone or teleconferencing. The robot they used was an RP7 remote presence robot, which had two-way video and audio, a digital stethoscope, and a printer which could make hard copies of orders and recommendations with the digital signature of the physician on the other end of the robot. They measured the participants' satisfaction with surveys, qualitative interviews, and other session information. Results showed that in 47 remote presence sessions, air transport was avoided in 60% of them, where previously it would have been considered. Doctors and nurses were extremely satisfied with this option. Among the benefits they found were its beneficial use in making real-time clinical decisions, enhanced interaction with nurses and patients, better collaboration between nurses and doctors, decreased stress levels, and the ability to facilitate retention and recruitment of nurses to remote northern communities in Canada. Patients were also just as satisfied with the robot. The advantages to this type of healthcare in rural settings are numerous. Most importantly, it reduces air transport costs, which could significantly improve the cost-effectiveness of healthcare in rural Canada, and thus the overall health outcomes. This type of robot presence has also been used in cases in the ICU, with stroke patients, and during laparoscopic gastric bypass. The potential for further technological development gives this remote presence robot great potential for continued and future success. Well, if you made it to the end, thanks for watching. That about sums up 3 of our required readings regarding health services in rural Canada. It is obvious that we still have outcomes in these areas, but it's also clear that progress has been made. I look forward to reading and participating in the online discussions with you all.